Thank you so much. This is really exciting because this will be the first time I'm actually talking to people not inside a technology bubble, but actually potential customers for what we've been working on for so long. Thank you. And let's see. And I'm very excited because this is actually real. What I'm going to show you, a prototype has now been installed in the frozen section room, and it's really easy to use. In fact, I had a couple of people from Nikon who came over to see what it was all about, and they were very excited because they were able to use it. And I said, you know, it's so simple, even a physicist can do it. So if a physicist can do it, maybe even a physician can do it. So just a word about me and then what I'm going to talk about. But before I do that, I'd like the lights to go low because that way you can all read your cell phones easier. And secondly, it's all about the pictures, and I want you to experience them. And I want to apologize to you. I haven't sort of told you what I'm going to talk about, but it's a new kind of microscopy. And even though there are a lot of functional and practical benefits, I keep getting swept up just by the sheer beauty of the images, and I realize that I'm appreciating them from a histology perspective. But I think even from people who don't live and die with H&E, you can see that there's some new things and wonderful sort of aesthetics to it all. And secondly, please interrupt me as we go along. And third, I consider this talk fractal. In other words, it's sort of self-similar, and if we run out of time, it's just that you'll not see the final set of pretty pictures, but you'll have gotten the whole point as we go along. So just a word about me. I am a pathologist. I'm board certified. I was at Duke University and for a while, and then I left to actually join industry, which was very exciting. Before I did that, actually, I went to Carnegie Mellon, which is not a medical school, to work on technology, mostly multispectral imaging technology. And that was for 3 years, and then I had a choice of going sort of back, stay in academia or go off to industry. And I thought, actually, things had not been going that well in academia. I tried industry, and so I went for actually 10 years at a company and developing multispectral imaging tools, which were ultimately bought by Perkin-Elmer and are still being actively and successfully used. And then that didn't go well, so I spent 3 years as a consultant working from one of my bedrooms in various technologies. And then, to my great surprise and pleasure, I got a phone call about 7 years ago saying, would you like to be a professor at UC Davis? And I said, sure. And here I am. I've been here about 6 years, and it's been wonderful. And basically, the sort of short version of all that is things happen unexpectedly and can have remarkable outcomes. And one of the great things that happened, as I'll briefly touch on, was when I got here, an old optics friend of mine said, hey, you should see what I've been doing at Lawrence Livermore. And he showed me what turned out to be the basis of what I'm going to tell you about. So it's all about good luck and good friends. So what I'm going to talk to you about finally is a new approach to rapid tissue diagnostics called MUSE, which stands for microscopy with UV surface excitation, and I'll explain what that means. It also stands for microscopy with unusual speed and excellence, and I'll try to document that. And we have, and also I wanted to start with this. This is what? What's that? Yes, beautiful forest scene. It's actually our Christmas card, and it's actually a wart from the bottom of a foot from some unfortunate person. The blue things are nuclei. That's the epidermis. This is the dermis. The orange stuff is elastin. So, but it's also a Christmas scene. So, I do have a disclosure. I'm happy to say that we've misspelled MUSE right here. It's a company. I hope that we are about to get some serious money. We've been basically operating on fumes 50,000, not quite fumes. We got a STARE grant from UC Davis, which was very helpful, and actually helped build the prototype, one of which is now in frozen section room. But I hope that we have now attracted some serious investors, and in the next few weeks we should translate into a real company. So, and I'm also happy to say that we're on the cover of this month's Nature Biomedical Engineering. That is what? It's a blood vessel from spleen. Image taken by an undergraduate. So here's the problem that makes it relevant to what you guys do, which is it takes a long time to get from the tissue bit to the answer bit. And of course, frozen sections drop that down to 10 or 20 minutes. But as you know, there are problems with frozens. They're hard, they're expensive, and sort of all the infrastructure. And they require different kind of staffing and expertise. And the histology is not always that great. So this is a Macintosh problem. It says guidance, not guidan. You know this stuff. Stuff looks funny, but you don't know what it is until you do the histology. And here at UC Davis, we use state-of-the-art technology typically to analyze these things, and this hasn't changed for 150 years. We use microscopes that give light from underneath. The only thing that's different between that microscope and what we use now is instead of the sun, we have an LED, but that's the same. The slides are made the same way with histology, with formalin and paraffin and slicing. And, it's embarrassing. Some people says they're embarrassed when they go to fancy conferences because everyone shows, RNA-seq and wonderful things, and then the pathologist gets up and they show pink and blue, and it's been true for, 100 years. So the problem with pathology is based on the problem with the microscope. It's a transmission microscope. The light comes from below, goes through the tissue, and ends up above to your eye or a camera. And, if you're going to too many layers, it's going to be too blurry. And so our solution is to cut the tissue very, very thin. And that sounds easy, but it's not because it takes lots of steps. And I hope I have a slide that demonstrates that in a second. But otherwise, you're trying to read a book 6 pages at a time. Everything gets blurry and confusing. So there have been people now realize this, and there are actually lots of different technologies for coming up with diagnostics that don't involve making a slide. But when you're heading off into sort of novel technologies, things need to not only work technically, they need to work financially and operationally. And so if you think about what you would like to see in a new technology, this is my version of the desirable properties. You want something that's simple, doesn't look like the thing on the top left. You want it cheap, so it doesn't take all the Fort Knox. You want it to be user-friendly, and there's a friendly pathologist there. And it would be great if it were global, too, so it's not just a solution for UC Davis, but for under-resourced areas like Rwanda. And that's a challenge. So I just want to show you a couple of images of what other people are doing. I'm actually working with some of these guys. This is Jonathan Liu at University of Washington, Seattle. It's a, sorry, these things are in white, but basically this is something called light sheet microscopy. It's one of the optical ways of getting a thin image from thick tissue. And you can see that it's complicated and expensive. That camera alone, I think, costs between $20,000 and $40,000. But it makes pictures. This is a different version. This is something called structured illumination. This comes out of Tulane. And on the right is a standard H&E, and on the left is a quickly acquired image of prostate, stained, but imaged from a thick piece of tissue in just a few seconds. And it's okay. It sort of shows the pathology, but the achievable resolution with this system is a little bit under par. And again, you can see there's some complicated optics involved, optics and electronics. This is just another version of that showing they do a pretty good job. You can actually take these images which are, not H&E, and you can pseudo-color them so they look like H&E. So this is, again, another, I think, structured illumination version from thick tissue. So now I'm having given due credit to the other people in the field, and there's another group at MIT that's using multi-photon microscopy, which is great, except the instrument costs $800,000. But the images are lovely. So now I'm going to turn to MUSE, spelled M-U-S-E, not M-U-S-Z-E. And this is the guy who introduced me to the concept when I came to UC Davis, Stavros Dimos. He's now at University of Rochester. And he had a tunable laser. And as you know, anyone with a tunable laser wants to tune it and see what happens. So he was tuning it wavelength-wise from the visible range all the way down to the fairly deep UV, and looking at a fresh piece of esophagus and expecting that he would see different things fluorescing as the wavelength changed. And if that, in fact, happened, but what was unexpected, although obvious in retrospect, was that the quality of the image changed as the wavelength got shorter and shorter. And so this is exactly the same field of view, imaged at 408, which is blue, which is sort of in the visible range, then a little bit of UV, and then deep UV, and you can see it's sharpening up. And I'll explain why it's sharpening up, but this basically indicates another way of getting basically images from a thin part of the specimen even before you do any sectioning, physical sectioning. So he told me about it. He actually sort of gave us his rig, and then I and my project scientist, postdoc at the time, I guess, started to build and develop new instruments based on this design. And this is what basically he shared with us, and this is still the basic design that we are working with. And it's, in contrast to what I showed you before, it's really, really simple and potentially extremely inexpensive. Although, if you want good optics, you have to pay good money. And what you see is this going to work? Yeah, look at that. The essence is simply a UV LED, and you can buy LEDs that emit at 280 nanometers, which is what we use. And they're cheap now. They're like $50. And this is the specimen, and it's any size specimen. It can be, an inch thick. All we're looking at is the surface that's stuck down or just pressed down against this UV transparent window, which is, we typically use sapphire, which is now very inexpensive. It was going to be used for, I think it is used for Apple Watch faces. It was going to be used for the iPhone. You can buy a big thing of this like for $16. It's stained. We stain the tissue for 10 seconds or as much as 30 seconds with different stains. And then it gets excited with the UV, and then the emissions come down through a regular standard microscope objective and into what we're using is a standard color camera. So there's really nothing exotic here. And the other thing is we actually color, and these are color images, and we can see them instantly. There's no mathematics involved. And there are ways of making this battery and cell phone compatible, and this is the kind of thing that could really work in Rwanda. So on the left, this is how we do biopsies, how you guys do biopsies at UC Davis. And then that technique is followed by formalin fixation, paraffin embedding, which involve these steps, which are not exotic, but they aren't easy to do if you don't have a histology lab. And there might be 3 labs or 2 labs in all of Rwanda, for example. Or if you're up in Chico, California, or Chester, California, the histology lab may be 20, 60, 100 miles away. And so you have to send whatever it is you want, by FedEx or by courier somewhere, have something happen, and then have it couriered back if you're not using digital pathology. And that can take a week or 2 weeks. But at the end of it, you get this nice image of colon cancer. But it takes, at the minimum, overnight here. Or you can use our technique and get this in 3 minutes from fresh tissue. which is where you guys come in, because this is what we can do for biopsies, for frozen sections, for margin determinations. All of these things are potential. And what I didn't say is that in the new year, this year, I hope to be working with many of you to actually test this out with the instrument that we have in the frozen section room, to compare with frozen sections, to compare with FFPE, and really see if we can knock off either 20 minutes or 1 to 2 days off the whole cycle of diagnostics and surgical guidance. So this is my postdoc, who I hope to be keeping here, but he's being pursued by other institutions now as an assistant professor. That's Farzad Feriduni. And I think what's not clear is the microscope is just this little blob here. All the rest is unrelated black stuff. And this is the technique. You just take a piece of tissue. You can make it flat if you need to. Otherwise, if it's fresh, it's squishy, you just gently compress it against a flat surface. Stain it for 10 seconds. Rinse it in water or PBS for 20 seconds and capture images at 10 frames a second. In other words, it's pretty fast, and you can image large fields of view. And the box that's in the frozen section room actually has an imaging area of almost 5 centimeters by 5 centimeters. So you could look at half or a whole small prostate, large chunks, much larger than will fit on a slide. There it is. And that's the box in the frozen section room. We have 3 boxes. They're called Alice, Bob, and Carlos. This is Alice. Come and see it. So what are the problems that MUSE might be able to solve? Well, as you know, we're in the era of precision medicine. And that means that people want to get more and more information from ever smaller pieces of tissue. And there's a needle biopsy compared to a needle, and it's small. And one problem is you don't know if there's anything good in there or not. So somehow you need to know if that needle biopsy actually caught the tumor or not, or whether it's all fibrosis or necrosis or normal tissue. And then secondly, as you do the various diagnostic techniques, what you've got left gets smaller and smaller. So this is what you have after a frozen section. And then when you take that out and submit it for permanence, that's what you end up on the slide. And then they say, well, did you get the DNA, the RNA, the epigenome, the metabolomics from that? So that's the problem. If we can replace the sectioning steps with a microscope, get all of the microscopy that you need done directly from that needle, and it's all still there after you've done the MUSE, then you can drop the right part of that needle directly into liquid nitrogen and do RNA-seq or whatever it is you want to do, or immunohistochemistry. And we're actually working on techniques to do high-speed IHC or immunofluorescence directly on that within minutes, not hours or days. And so MUSE is, as I said, non-destructive and preserves samples for molecular studies. So again, here's a sort of storyline. In the developed world, it's cheaper, much faster, and it's non-destructive. And as I keep talking about Rwanda, because I have a colleague who's coming here this month, and I hope you come, to talk about point of care and breast cancer diagnostics in the third world. She's a surgical pathologist at Brigham's and Women's in Boston. And so she'll be giving a talk here, and I hope I'll try to get the word out to you. Because the challenges in Rwanda go far beyond just the diagnostics, of course. It's the whole care and therapy chain that needs to be optimized. And in low resource settings, if you can't do histology, you can't get any diagnosis at all. And so that's shown down here. Basically, the pinker areas are the more challenged areas. But you can summarize it like this. Grumpy Cat says, no slide, no diagnosis. And so hopefully if we get rid of the need for a slide, we can get rid of this problem. So let me just talk briefly about how MUSE works. And it takes advantage of some features of tissue optics. I'm showing this here just to intimidate you, but light goes through tissue and interacts in various ways. It can go straight through. It can scatter and still go through. It can be absorbed and stop, or it can be scattered backwards. And the point is that all of these phenomena are very, very wavelength dependent. And as you go down into the UV, the absorption and scattering, mostly absorption, becomes dominant because, as you probably remember, UV light is very strongly absorbed at 280 and 260 by protein and DNA, and that's what tissue is, apart from the water and the fat and the carbohydrates. So this is some example of just the effect of wavelength on penetration from the surface into skin. And the wavelength is shown at the top. From far red, it goes way down to 3 millimeters. And at 420, which is still visible in the blue, it's only going down 100 microns. 100 microns is still much too thick to do histology. As you know, slides are typically 4 or 5 microns thick. So 420 doesn't work, but deeper does, as I already showed you beginning, the difference between 405 and 266 makes a big difference. So that's function one of why MUSE works. The other reason that MUSE works is that UV light in this wavelength can excite many, many different fluorescent dyes at once. And this is very different from standard fluorescence microscopy, where if any of you guys have seen it or done it, been exposed to it, you know that each color, if you want red emissions or green emissions or blue emissions, you need a different excitation source for each one of these dyes, because what's called the Stokes shift, the difference between the excitation wavelength and the emission wavelength, is typically very small. And so if I wanted another dye to emit out here at 700, I would need to be exciting at 650, 680. So that makes for very complicated optical things. Fortunately, with MUSE, I'm going to skip this, but this is sort of the new mechanism. It turns out that light at 280, using a different excitation regime than standard fluorescence excitation, can excite all of these dyes simultaneously with a single UV source. So that makes it very easy. And the other interesting and important point is that even though we're exciting at 280, all of these dyes are emitting in their normal visible visual range stuff. So rhodamine is still red, eosin is still greenish, etc. So all of your interpretation optics and immunolabeling should be the same whether you excite standardly or at 280. So let me show you the first thing that Farzad did. He went out and we needed some tissue. Instead of getting some real tissue, he went out to a grocery store and bought some halal frozen lamb kidney and stained it with eosin, and it's been frozen for 4 months. We looked at the date. So it's falling apart a little bit, but this is what we see at 405 nanometers, which is, again, in the blue range, not in the UV range. And you can see there's stuff there, but it's very hard to sort of see what's going on. If you just don't do anything except switch to 280, now you can see that. It's exactly the same field of view, but now it looks like scanning EM. And those are tubules and collecting ducts and stuff. So let me switch now. That was a grayscale camera. Let me show you now some images of and some properties of what we've seen. First of all, we're looking at thick pieces of tissue. So there is information from below just the plane that we're of the stage. And so, for example, this is a kidney vessel artery in pig kidney, stained for 10 seconds with just 2 dyes. But you can see it's a rich color output, and this blue stuff is collagen. This is a vessel. These are tubules, and I think if close up, you can see down into the artery, and you can also see this very nice elastin, external internal elastic lamina, which turn out to be very important in pathology. People go out of their way to do special elastin stains. We see elastin free. Just it happens to be that the stains that we use light it up, and this can be very important in colon cancer, for example, because some invasive cancer, you can't even see that it's gone into the vessels because it's destroyed the vessels around it histologically. And the only way you can know there was a vessel there was that if you do an elastin stain, you can see a little bit of shattered elastin where the cancer now is. So this might be very useful in upstaging colon cancer, for example. And what I'm going to show you really has not been substantially retouched or altered from what the camera captured. All we're doing is taking what may look sort of boring, this green on green thing, and doing something that's very simple in Photoshop or GIMP, which is a free version of Photoshop. If you just do auto white balance, it basically stretches, makes the brightest thing white and stretches all of the other colors. And so that's the only thing going from here to here. We're not doing any sort of complicated color remapping in this set. So all of the color images I'll show you have simply been auto white balanced, and this can be done, in real time. And so here's an example of an auto white balance, another example of kidney. I just love these vessels. So again, the elastin is bright, and this blue stuff here is autofluorescent collagen. And this is likely to be useful in various renal pathologies that we can look at, or looking at donor kidneys, for example, to see whether they're adequate to be transplanted or not. And you can also do unmixing. So this is a little more computationally intense, where you can actually pull out the different features, pseudo-color them, and now the elastin is green and the collagen is blue. And if you want to do something quantitative, this would be a nice way to do it. But pathologists are stubborn, and they only want to look at H&E. So fortunately, there's a way to take the images that we acquire, which is the stuff on the left here, and map them into stuff that looks like H&E. So that's exactly the same image, and there's just a tool. This is a development tool that allows us to fiddle with settings to get something that looks pretty pathology friendly. And then this would all be hidden from the user and would simply happen in real time. So let me show you now. So that's the story of MUSE, and now I'm going to show you pretty pictures. So any questions on the thing? Yeah.
Is the picture you see with the naked eye the pre-auto white balance image?
Yes, that's what you would see. And there may be ways of choosing different stains and different concentrations to make that a little more vivid. But we don't actually look at this by eye. It all goes. There are no eyepieces in our system, although there could be. Yeah.
You said that it doesn't destroy the tissue. So if you're staining it, how does that affect it for other uses?
Excellent question. And the NIH gave us a three-year R33 grant to show that it doesn't do much. But we've done IHC, fish, ISH, and RNA-seq on a few specimens, and we don't see any consequences. So far so good, but we need to do it very carefully. But the first pass is that we don't see any effects. And we can also take the tissue, do MUSE staining on it, submit it for regular FFPE and H&E, and it looks perfect. It doesn't affect standard histology either, which is good. So, so now we're in example land. On the left is a FFPE standard histology of thyroid papillary carcinoma of the thyroid. On the left is, as I said, standard stuff. On the right is basically a section from almost the same area, imaged with MUSE, and you can see that it's easy to tell again the difference between the normal thyroid section and the cancer, and then we can take the one on the right, which I'm comfortable looking at, but turn it into H&E to make other people happy.
That's not on a fresh specimen?
That was probably fixed. Most of what I've shown you is fixed, simply for convenience, but there's actually fresh specimens can look better than fixed. The nuclear histology actually looks good. We can see chromatin texture. And here, in fact, about that is we're only using a 10x lens, but it's still good enough to show us mitoses and chromatin. And as we get better lenses, we can improve on this even further. So on the left is MUSE, on the right is conventional, and there are two panels here. One shows the chromatin, and the other shows the example of mitoses. And the arrows are conveniently help you guide your eyes. So one of the really important things that we're going to test very carefully in the coming months is how this compares to frozen sections. And our initial sort of casual impressions are that it's potentially much better. So what I'm showing you here is the same specimen, lung adenocarcinoma. The top two panels are MUSE. This is from fresh tissue. And then on the right here is a color mapped version of this is exactly the same image. And then the bottom here is what it looks like on standard H&E. And on the left, bottom left, is what it looks like on frozen section. You can see there are large areas of basically frozen artifact where ice crystals were, where the cells have sort of fallen away from each other. And you can see this isn't good, but it's certainly not as probably reflective of what's really in the tissue as either MUSE or the FFPE. So we're going to explore this with far greater rigor going forward. The other nice thing, sorry for this greenishness, is that we can look at very large areas. I said we've already got a 5 by 5 centimeter capability, but it could be, if we built a bigger stage, we could look at whole brain slices, whole kidneys, whole whatever you want. We're only limited by how far things move. And so this is a stitched, multiple images of a spinal cord. And then to show you its high resolution, we'll zoom in there, and now you can see these are motor neurons here. This is leptomeninges here. This is a peripheral nerve root here, and you can't really see it, but you can actually see one of the things I love saying in a very strong fake French accent, the nodes of Ranvier, which are the sort of periodic horizontal or sort of transverse markings along a nerve. So this is, and we've seen, I think I may show you another brain or two. This is very promising for brain morphology as well as brain biopsy assessment. And I've been working with Myrna Leckpalmer, who's one of our neuropathologists, and she actually did a study showing very good correlation between what we saw in MUSE and what was in the final H&E for brain lesions. So this is what H&E looks like for atypical ductal hyperplasia, and you really don't need to convert to pseudo H&E to see that this is showing you very similar things, especially when you're looking at just structure and organization. The native MUSE images are just fine for most of these things. One interesting thing is we actually see more colors than you normally see on H&E. So here is this is urothelium from a pig, so it's not really clinically relevant. But here's a blood vessel. Here's a vein here. You only know it because it's sort of slit-like and near an artery, but it doesn't look like much. And then I have 3, 4, and 5 are different stromal regions next to this bit of urothelium up here, and I number them not because from the H&E they're that obvious, although 3 is different from 4 and 5, but these are really subtle. Here's the MUSE equivalent of the same region. There's the artery now, but now you can see the elastin. And this is the vein. It's moved a little bit in position, but you can see the endothelium actually stains differently, whereas here you can't see anything about the endothelium. And now it's really easy to see these little tiny vessels here, and it's very challenging to impossible to see small vessels here in the H&E. So this is already better than H&E. And then look at 3, 4, and 5, blue, orange, greenish, whereas before it was pink, pink, and pink. This is exciting. We haven't gotten very far with this yet, but it could open a whole new realm of pathology and staging. For example, some of you may know that there's a lot of interest in the stroma around breast cancer and particularly prostate cancer with, and I'm hoping that this will show us or make it easier to see differences between sort of benign and malignant stroma. Just a picture of liver. This is H&E, standard liver. And then here's our version stitched together, so we can stitch without artifact. And then you can zoom in and see this nice portal triad with a portal vein here and here. This is a bile duct. Here are little small arteries here. This is now a fairly large area stitched together of infant cerebellum. And this is what it looks like with our dyes and standard imaging. And then this here is H&E converted from here. And it really looks very convincingly like a standard histology. But again, it just took a minute. And as I said, we're seeing novel things that you don't really see in H&E. And one of the nice things is that we can actually, these orange, these are come on. Sorry. These are neurons, and they're orange. And the reason they're orange is they've been stained with a dye called propidium iodide, which stains RNA and DNA. And the bright orange means that there's lots of RNA in them. You can see other cells around. Here's a little more capillary blue things, which have no RNA, essentially. And in some tumors, we can see regions, well-vascularized regions that have lots of RNA, and then poorly vascularized regions don't. And you can see an orange and non-orange thing. So I hope that we're going to actually have a functional measure of sort of activity, of how active the immune cells are, how active the cancer cells are, just based on the RNA present in the tissue. And this is really technically really easy to do. And if we treat the tissue with RNase, the orange stuff goes away. So we're reasonably optimistic that we understand what's going on. Now, we've seen new things, or things that you don't normally see with standard histology because of the way you have to orient the tissue. This is the face of the colon. This is what the endoscopists see, but you never see this on standard H&E. But here we're just looking at the face. The little circles here are the goblet cells releasing mucin, and you can see the connective tissue more or less surrounding each one of these crypts. And so this would make a very nice correlative study to what the endoscopists see, and could really help get the two fields working more in synchrony. So as I mentioned, we've done a few studies already to validate that it really does work. This is with Myrna, and the number down there says 97. That was our sort of correlation between the MUSE and the H&E for various brain lesions. And we did a more global study, just taking a bunch of things that came through the pathology department. So we pitted Sandy Borowski versus John Bishop. Sandy saw only MUSE images, native and color mapped, and John Bishop saw only the H&E. They didn't talk to each other. They had no clue, apart from the source of the tissue, what they were looking at. It just said ovary or breast. And then they wrote down freehand what they thought the diagnosis was. In 39 out of 42, they agreed totally. In 2, they were very close. And in 1, Sandy screwed up, which he acknowledged. So it's actually looking very promising. And to your question before, here's John McPherson in the Cancer Center kindly ran some RNA-seq on some needle biopsies of lung that were either mused or non-mused, treated in parallel. And all of the quality control metrics look identical between the two things. So now just some pretty pictures. This is skin, breast skin, very, very thin, not a big epidermis. This is the epidermis. This is the dermis. That's the basal cells, or the lining cells at the bottom of the epidermis. Here's another example of skin from the foot, I think, from a black African-American person. So you can see the melanin running right along here, this line. The yellow is elastin, the green is collagen, and this is actually very important in skin pathology to see disorders of elastin distribution. And it comes here free. You don't need to do a special stain. This is an eccrine, I think, sweat gland. And this, this is HIPAA compliant, as you can see. So she's almost 13 now. She's been throwing up nodules on her skin, and we were very fortunate last summer and now the coming summer to have a vet student come and work in our lab. So I got her lesions and had the vet not send them to pathology, but she just put them in formalin and gave them to me, and then Croy Griffin from the vet school imaged them. And I'm first going to show you not her lesion, but this is a sebaceous gland. On the top left is what it looks like on standard H&E. This is what we see with MUSE. It's just, as far as I'm concerned, more better. And you can see here that these cells are sort of breaking down and turning into sebum, and then going up this out-of-focus duct up here to become sebum to keep your skin looking youthful and glowing. And then this is what Croy saw from Tess's lesion. Tess, not her real name. And if you look closely, you can see that this is a sebaceous gland. The colors are different, but it's really got the same kind of structure. And the diagnosis was sebaceous hyperplasia, not a non-malignant thing, so she's fine. She was adequately treated. Then here's some other amazing pictures that Croy did over the summer. He was very interested in intraoperative guidance for the treatment of mast cell tumors, which are very rare in human, unfortunately very common and lethal in dogs. And you do have to, and with no good chemotherapy, so they're surgically treated, and you have to get a grade and get the margins right. So I'll just show you some mast cell tumor images, with special focus on the collagen. And so this is a conventional image of a mast cell tumor. The blue cells are the mast cells, and the pink stuff here is collagen. And you can see there's collagen in here, but you really don't see how it's organized. So this is an equivalent image taken by Croy. The yellow cells are the mast cells, and these blue things are these wonderful sort of strands of collagen. And you can really see that they're honest physical structures sort of doing things in the tissue. And here's another image.
Almost has a 3D quality.
Yes, because you get the 3D quality because it's not a thin section. You can see everything below the plane until you hit something. So it's seeing the world the way we see the world. I don't see all the way through you. That would be troubling. I just see your surface. And so the images are sort of interpretable by our brain because this is how we see the world, which I think is really cool. Here's another different stain, mast cell tumor, and now you can see how this is what collagen looks like in the skin. And these little orange cells are the mast cells. And here's another image, which is very striking, and I think we're going to learn new things. So again, mast cell tumor, collagen, and now I'm looking at this thing, and it's coming out of a pore or something in the collagen, and it's maybe a fibroblast. And here's a branch coming off here. We're seeing new things that really are going to need some very smart anatomists to understand what's happening. More collagen. This is crazy. That's surgical debris, this stuff here, the green stuff. But there was no special treatment. This is not EM. He stained it for a little bit, stuck it on the microscope, and this is what we saw. So I think it's going to revolutionize just how we see the microscopic world, all the way from education, from middle school, medical students, vet students, to even surgeons.
So since I know you could go on for quite a while with these fabulous pictures, I was thinking on the side you should just sell them as artwork.
I would, yeah.
Because it really is spectacular.
Thank you.
You also, so I think there's a lot of opportunity, and I'm looking around thinking, my transplant surgeons and my thyroid surgeons and lots of people, I'm sure, are already thinking what the potential applications for their fields might be. Talk a little bit, since we might have a little bit of time, I know some people have to go, about the challenges of turning what essentially was a lab observation, you and the
Stavros?
laser guy,
Yeah.
into a business, into something that might actually be marketable and useful to people. Because if you can't do that, just doing it in your lab doesn't get it to people.
No, and so that's the exciting part and frustrating part about starting a company, is that people get all excited about these images, and by the way, what is that? It's a test for you. But there's so many steps that have to be mastered, and if you screw up even one, then it all falls apart. The first one is intellectual property. So if there aren't patents or barriers to competition, then somebody else can just do what you do cheaper, faster, better from China. And in fact, if you have patents, they can still do it. Then you need to actually understand what the market is, what people want, because this is a great picture, but it has zero diagnostic and functional utility to anybody except muscle physiologists. Hint, that's muscle. Then you need a team. I've been in business, but I'm no businessman. You actually need people who will commit their time and skills to bring this forward, and it's not enough to take the PI and get one of your smart and ambitious graduate students say, okay, make a company. That's not enough. You need skilled business people who know how this works. And of course you need money, and you need regulatory approval, and you need reimbursement things. So all of these things need to come together for this to become real, and 9 out of 10 times it doesn't.
You mentioned views from the endoscopist point of view. What do you foresee the ability of this to be miniaturized into either an endoscope or an actual real intraoperative camera?
Well, I mean, a lot of people have asked that. I think it's very promising to think of this as in vivo microscopy as opposed to rapid ex vivo microscopy. There are two major problems, one of which is we only really see the surface, and a lot of people don't want to see just what's on the surface. Mostly that's cautery and blood, right? You want to see below that, and this is not good for that unless you've sort of got yourself inside on like an endoscope or a needle sort of thing, and you're really down into the tissue. Secondly, there are actually a lot of other competing technologies. There's confocal, multiphoton, OCT, stuff that are going into the, so you need to show that this is 10 times better or cheaper than everybody else. Third, it's frightening because it's UV, and people think, oh, you're going to give me sunburn and cancer inside my body. And then it also uses exogenous dyes, which also have bad reps, like Herxt or DAPI or even proflavin, all of which scare the FDA. So I think you'd need to be young and ambitious to take this on, because it's got many more years of work than simply looking ex vivo where you can do what you want.
Have you looked at, you haven't shown any other species, have you looked at bacteria or any kind of infectious invasion?
We've looked at sheep poop. The CAO in our department also raises, I forget what kind of sheep they are from South Africa. And one of the big problems there is parasites. And so we've actually looked at flotation stuff from there, and we saw wonderful parasitic things. Our current 10x lens is probably not that hot for seeing bacteria, so we'd need to boost our stuff. But there are certainly many, many different dyes, fluorescent dyes, that are easy to use. It will highlight bacteria or TB or various protozoans. So I think it's very promising, but we haven't done a lot there. I think for fungus it could work very nicely, and they're good, fast fungal dyes.
Let me push you a little bit on intellectual property, because I think you shared with me that you had a different experience working with Lawrence Livermore, or at least that there are tricks or things that one needs to know about this that you of course only learn by error, because no one knows how to do it the first time. Any thoughts on how to think about managing intellectual property, or when you get an idea or you're doing something innovative?
Well, there are two aspects to that, and especially related to the institutions. First is, you have to get the patents filed, and so that has to be paid for. And fortunately, the initial filings were paid for by Lawrence Livermore. And then you have to get it licensed. But of course, all of the IP belongs to Lawrence Livermore or to UC Davis, and then as a company, you have to license. And their first instinct is not to license back to the feckless academic, investigator who presumably knows nothing about business, but to put it out on the market and market it to Nikon and Zeiss and all these other big guys who actually know much more about what they're doing than the UC Davis Tech Transfer Office does, and so they may be able to sort of undervalue the intellectual property portfolio, get it for cheap, or misuse it, or abandon it, or only focus on one tiny field of interest to them and throw away everything else. And so its first challenge is, if you're starting a company, to license it back to your company and prove to the institution that you're the best shepherd of this IP. And then you have to do it under affordable terms. And Lawrence Livermore seemed to be striking a very hard bargain, but I've heard from somebody at UC Davis that the terms that they wanted here were usurious, really extremely greedy from the institutional perspective, enough so that it might even kill the company because the license terms were so hard to actually to manage. So you need a very skilled negotiator or a much more lenient and forward-thinking tech transfer office to make it work. And so that's a big challenge.
It's just interesting to appreciate, you know, the unique perspective that someone as a clinician has on a new technology, some guy with a fancy laser,
Mhm.
and then, but getting it from, wow, this could be a great idea, to how we're really going to make it work in humans, has a little bit to do with science, and it sounds like a lot more to do with all that other stuff.
Well, it's really, really nice. I mean, MUSE is lucky to have me in the sense that I'm in the field, I understand it. An awful lot of companies have only engineers and people who've been given tissue from who knows where, and they've worked up a technique, and they don't even know if it's meaningful in the real world. So at least I have some perspective on that. So one thing is to really understand who your customers are and what problem you're solving. But as again, that's only the beginning, as we sort of touched on.
We are a bit over time, but I
Okay.
think we've got, if there are other sort of burning questions, I think we can, what I noticed is whether or not I've got students standing in to get in, and I don't at the moment.
Okay.
So, anyone have any other questions?
So do you think with a bunch of different dyes that you create that you could supplant genetics chemistry with this? So we could potentially, it'd be as quick as a frozen essentially.
Yeah, you can do, I mean, I was just reading some papers on it. I'm working with a group at the University of Washington, but there are techniques that can do immunostaining in 11 minutes. And the thing is, if you add it to this, which means you don't need to have a thin section, don't even need to do a frozen section, you should be able to get ER, PR, HER2, boom, on the breast cancer biopsy within the hour.
It's pretty amazing. I really appreciate you coming and doing this at the first of the year. It is so, it makes Lydia Howell's proposition that we've done so much in the therapy side of medicine over the last decades, but the diagnostic side really the needle has not been moved very far, and it just makes it very prescient to think about, focusing more on diagnostics and how that could improve our therapies for everybody all along. So thank you for what you're doing, and thank you for sharing with us.
And very collaborative. Come see me.